Here's something that might surprise you. The same pill you take for a headache could reduce your chance of developing colorectal cancer by up to 40%. We're talking about aspirin, a drug that's been around for over a century, derived from compounds humans have used for 4,000 years. But only in the last 2 decades have we discovered its remarkable ability to prevent cancer at the cellular level. I'm Dr. Ferghal Armstrong, and today we're exploring the fascinating science behind aspirin's cancer-fighting properties. You'll learn exactly how this ancient remedy works against modern disease, which cancers it protects against, and crucially, whether the benefits outweigh the risks for you personally. Let's start with what's actually happening inside your cells. Aspirin works by irreversibly blocking an enzyme called cyclooxygenase, or COX for short. There are 2 types, COX-1 and COX-2, but it's COX-2 that's particularly important for cancer development. Here's why that matters. COX-2 produces inflammatory molecules called prostaglandins. In healthy tissue, this is fine. But in pre-cancerous cells, these prostaglandins do 3 dangerous things. They promote cell growth, they help tumors develop their own blood supply, and they suppress your immune system's ability to recognize and destroy abnormal cells. When aspirin blocks COX-2, it's like cutting off the fuel supply to potential tumors. But that's not all. Aspirin also reduces platelet stickiness in your blood. Why does this matter for cancer? Well, because circulating cancer cells often use platelets as a shield to avoid detection by your immune system and to help them stick to new locations during metastasis. The strongest evidence we have is for colorectal cancer prevention. Multiple large-scale studies show that taking low-dose aspirin daily for 5 to 10 years reduces colorectal cancer risk by 20 to 40%. That's a significant reduction for any preventative intervention. But here's what's particularly interesting about the timing. The protective effect doesn't kick in immediately. It typically takes 3 to 5 years of regular use before you see benefits. And remarkably, the protection can persist for years even after you stop taking aspirin. The mechanism here involves aspirin's effect on adenomatous polyps, those small growths in your colon that can become cancerous. Research shows aspirin reduces both the formation of new polyps and slows the progression of existing ones to malignancy. While colorectal cancer has the strongest evidence, emerging research suggests protective effects against other cancers too. Studies indicate potential benefits for gastric, esophageal, and even some breast and prostate cancers. The evidence is less robust than for colorectal cancer, but the mechanisms make biological sense. Many of these cancers have chronic inflammation and COX-2 overexpression, exactly the pathways aspirin targets. What's particularly intriguing is recent research into aspirin's role in cancer immunotherapy. Some studies suggest it might enhance your immune system's ability to recognize and attack cancer cells, though this remains an active area of investigation. Here's where precision matters. The optimal dose appears to be low-dose aspirin 75 to 100 milligrams daily. That's the same dose recommended for cardiovascular protection. Higher doses don't provide superior cancer prevention, but do significantly increase bleeding risks. Duration is equally important. Cancer prevention benefits require sustained long-term use, typically 5 to 10 years minimum. This isn't a short-term intervention. Think of it as a long-term investment in cellular health. The current Australian guidelines, following international consensus, recommend considering low-dose aspirin for adults aged 50 to 59 with elevated cardiovascular risk, noting cancer prevention as an additional benefit. But this requires careful individual risk assessment. Now for the crucial balance. Aspirin increases bleeding risk. There's no getting around this. The annual risk of major bleeding ranges from 2 to 4 per 1,000 people taking low-dose aspirin. That includes both gastrointestinal bleeding and, more rarely, brain hemorrhage. Age significantly affects this equation. After age 70, bleeding risks increase substantially while cancer prevention benefits may diminish. This is why individualized risk assessment with your healthcare provider is essential. Contraindications include active peptic ulcer disease, bleeding disorders, severe liver or kidney disease, and concurrent use of blood thinners. If you're taking warfarin or other anticoagulants, adding aspirin is generally not recommended. The decision comes down to your individual risk profile. Factors favoring aspirin include family history of colorectal cancer, elevated cardiovascular risk, and age between 50 to 69. Factors against include history of bleeding, peptic ulcers, or significant bleeding risk factors. Here's a practical approach. If you're already taking low-dose aspirin for cardiovascular protection, the cancer prevention benefit is essentially a bonus. If you're considering aspirin solely for cancer prevention, the decision becomes more complex and requires healthcare provider consultation. Remember, this is preventative medicine, not treatment. Aspirin won't cure existing cancer, but it may help prevent future malignancy in appropriately selected individuals. The relationship between aspirin and cancer prevention represents one of the most compelling examples of how well-established medications can reveal new therapeutic applications. But as we've seen, the decision to use aspirin for cancer prevention is not straightforward. It requires careful consideration of your individual risk factors. What's your experience with preventative medications? Have you discussed aspirin therapy with your healthcare provider? Share your thoughts in the comments below. I read every single one and often respond personally. Thanks for watching MedHeads. Until next time, stay curious about the science behind your health.